Hey everybody, we are back and talking about white blood cells and the different types of white blood cells. I'm going to switch to screen share mode here so you can see what I'm talking about. We left off talking about hemolytic disease of the newborn in our last lecture. White blood cells, WBCs, leukocytes, same thing. They have some shared properties, right? They have a short time that they spend circulating. They're mostly kind of waiting in the wings of our connective tissue. So they're waiting where in the underlying tissues of the dermis, waiting in the reticular tissues, just waiting to be called to action, pretty much. They can migrate out of the bloodstream and come back into the bloodstream. So they're migratory. They don't just stay in the blood all the time. Some of them do, but not always. They can adhere to vessel walls. They can adhere to close to infection sites. They can squeeze between endothelial cells to kind of get through to different tissues. So they're very dynamic. They also can be attracted by chemical stimuli. So if there is damaged tissue in the area, they can kind of smell it in a way. They detect the chemicals and they migrate towards that. It's called positive chemotaxis. Chemotaxis. Taxi or taxis is referring to movement. Chemo is like chemical movement. So they're moving towards the chemical that they sense. This is going to help guide the white blood cells towards pathogens, any site of injury, as well as activate other white blood cells. Neutrophils, eosinophils, monocytes, they're all phagocytic. So they're all going to basically act as Pac-Man, coming through, gobbling up and eating any debris, old cells, tissues, anything that doesn't belong there. These eosinophils, neutrophils, and monocytes are going to help get rid of those. So on average, we have about 7,000 white blood cells per microliter, much lower concentration than our red blood cells. And if there's infection, inflammation, allergic responses, that number can increase. Hence, why doing like a differential cell count can help be diagnostic. A differential count is typically reported as a percentage. And again, that's a diagnostic tool. Let's talk about the types of white blood cells. Here's where I would make a graphic organizer. I would, and I can show you. I still have my blood type stuff on here. Let me erase it real quick. So this is what I would have on my paper. Again, I'm a visual person. Most of my students I find are visual. Switch here. Okay. So white blood cells would be at the top, and then we break them down even more. So our white blood cells can be classified into two categories, granulocytes and agranulocytes. Okay, granulocytes have a grainy texture to them. So this is just a model. I'm not going to have enough room on this teeny tiny whiteboard to do the whole thing, but I will just wanted to show you what I think you should do it as we lecture through this. So go back to screen sharing here. So those granulocytes or granular leukocytes, these have lots of grains or granules within their cytoplasm. So they actually look like little dots in their cytoplasm. If you've had lab already, remember what those neutrophils, eosinophils, and basophils look like. They almost look like they have clumps inside of them. So neutrophils are the majority of our leukocytes, 50 to 70%. Eosinophils and basophils, a very small percentage. So in other words, when you are looking under the microscope at your blood slide and you find a white blood cell, more than likely it's a neutrophil. When you look at those neutrophils, that you will see that they have clumps in them. So the agranular leukocytes are the monocytes and lymphocytes. These are very smooth in appearance and don't have those lumps and bumps in them. So let's take a look at them here. Our granular leukocytes, and this is where you break it down even more, right? Granular leukocytes, neutrophils, eosinophils, basophils, agranular leukocytes, monocytes, and lymphocytes. And we can break them down. And off your graphic organizer, I would put the function on there because that's the most important thing in my opinion, what the function is, right? You want to know what it does. So neutrophils, they're phagocytic, right? Most abundant phagocytic. Eosinophils, phagocytic. Eosinophils are also responsible for getting rid of parasites. And then basophils are more of an allergic reaction. So these are responding to histamine and heparin. So they're more responding to like an inflammation or an allergy type response. So this is how I remember them. Neutrophils, these are just the neutral guys walking around gobbling things up. Eosinophils, just that word itself, it sounds like a worm. Eosinophils. I just picture this little like worm kind of like crawling through my blood. Ugh. But that's how I remember it, right? Be weird and you'll remember it. The basophils, think about this. Basophil, right? Think about sneezing and saying the word basophil. And that will help you remember. Basophils, sneezing, allergies. Okay, that's what they do. Hope that helps. I'm a little weird like that. All right, monocytes. These can actually come into and out of tissues. Don't have a weird way to remember this. You just got to remember this is the big guy with the boppy pillow looking like nucleus that comes in and out of tissues. It can sit in a connective tissue and then it can go into the blood and vice versa. It's also macrophages, phagocytic, so it's gobbling things up. And then lymphocytes, these are the little guys. These are involved in specific defenses. We're going to learn all about these in our immune system chapter later on. You can pause the video here, go back and review. We are going to continue in this lecture video talking about the process of clotting or hemostasis. Hemostasis is the process of stopping blood from clotting, pretty much. So it's responsible for stopping the blood loss through vessel walls. It's also going to get a new framework of tissues built in there where the damage has occurred. And there's three major phases. There's a vascular phase, a platelet phase, and a coagulation phase. So let's talk about what goes on in the vascular phase of hemostasis. About 30 minutes after the injury, this is occurring. So the endothelial cells are contracting. So there's an underlying basement membrane that's going to be exposed. This endothelial lining is going to release little chemical hormones called endothelins, basically stimulating this vascular spasm. So all of those tissues that are in there are going to basically retract and allow more blood to come to the area to flush out that area, right? So it's creating this spasm of kind of constriction or restriction, and allowing this blood flow to come in, wipe out all the broken stuff, get out all of any pathogens that might be sitting there lurking, trying to get in, right? This is also going to help bring in new fibroblasts and new fresh cells to help repair the area. So the endothelial membrane is actually going to become sticky. So this endothelial membrane, which kind of retracted, has little sticky attachment sites on it. And this is where cells will start to kind of latch on and stick. And in very small capillary cells on the opposite side of the wall can start to stick together to prevent like the blockage of blood flow. This stickiness is going to help facilitate platelet attachment. And so here you see this vascular phase. You cut your finger with a knife and it's bleeding, and this vascular spasm, see how it pulls it apart, right? It's going to restrict that area, open that area up so that blood can flow through and clean up any junk that may be sitting there. So now we have our platelet phase. Their vascular phase is really just about creating sticky area for our platelets to conglomerate around and enlarging that space to kind of wash it out. Our platelet phase begins with those platelets beginning to attach to that sticky basement membrane. Those collagen fibers are going to allow for this kind of net or mesh almost for the cells to start sticking to as they're flowing by in the blood. There's a chemical that's released by our platelets. ADP, adenosine diphosphate, is basically going to allow for the platelets to aggregate and secrete. And these chemicals that are basically accumulating in this area are going to continue that vascular spasm. So platelet factors are going to be released. There's also something called platelet-derived growth factor, PDGF, promoting this repair process as well. Calcium ions are there as well. So the platelet phase is just about getting the platelets to stick and moving this process forward through the release of chemicals. So Here you see the platelet phase. We have all of these platelets conglomerating. You have all of these platelet factors being released, just moving this process forward. Now we have our coagulation phase. This is going to start, again, 30 seconds or more after damage. This is a very, very quick process, right? Your blood doesn't want to be leaking out everywhere. So this process is basically a chain reaction that ends with the conversion of fibrinogen. Fibrinogen is a plasma protein. It's floating around your blood right now. But this coagulation phase ends with the conversion of that fibrinogen to fibrin. Fibrin is insoluble. Fibrinogen is soluble. It's floating in your blood. The end phase of coagulation, the last step, is converting fibrinogen to fibrin. So all of the steps leading up to that is just this chain reaction that ends with fibrin. So all of these blood cells are going to be trapped in a fibrin network. There are procoagulants or clotting factors that play a key role. There's also calcium that plays a key role, vitamin K that plays a key role, proenzymes. There's also activated enzymes. This is a whole cascade reaction. It's very complex. I'm just going to point out exactly what you need to know, though, from this whole chain reaction. So there's that kind of mesh network that we're trying to create, this kind of like a filter system to catch anything that goes through to stop that bleeding process. So there are two pathways that occur to get the clot to form. One is called the extrinsic pathway. The extrinsic pathway is happening on the outside surface of the vessel. So this is going to use something called a tissue factor. So the tissue factor is going to basically combine with calcium and activate this thing called factor X, right? So the intrinsic pathway is happening on the inside of the damaged vessel. So if you have a cut surface, you have an outside and an inside to it. The extrinsic pathway starting on the top of my hands here, which we'll just call that the outside of the vessel, and then the inside of the vessel's down here. This is going to be the intrinsic pathway, and they're basically going to meet in the middle. If the damage is right there, they're going to meet in the middle. The intrinsic pathway is activating proenzymes. Proenzymes are basically going to lead to, again, the activation of factor X. So PF3 or platelet factor 3 is another factor that's going to play a role in this intrinsic pathway. So the common pathway, which is activated by factor X is converting a protein known as prothrombin into thrombin. Then thrombin converts fibrinogen to fibrin, and that's our whole clotting process. Let's diagram it out. Stop the share. Go back here. We have our little graphic organizer that hopefully you made about white blood cells. Let's talk about our clotting process. So our clotting process has an, can label the whole thing, clotting, right? We have an extrinsic pathway. This is more superficial. And we have an intrinsic pathway. This is the deep, right? This is inside the vessel. This is on the surface of the vessel. So extrinsic pathway is using tissue factor. Intrinsic pathway is using platelet factor. Both of them activate, they come together to activate factor X. This is called the common pathway. The common pathway begins with the activation of factor X. Factor X converts prothrombin to thrombin. I'm drawing the arrow. That's what factor X does. It's acting as a like a catalyst, right? And then our thrombin is converting fibrinogen, to fibrin. So that's what thrombin does. Thrombin converts fibrinogen to fibrin. Fibrin is our clot. right? If you've ever looked at a clot before, I'm sure you have, a scab, right? You've all picked a scab before and looked at it, admit it, right? You see it's kind of like little tiny hairs in there almost. That's the fibrin. And then all of the red stuff is just the clumped up red blood cells. So that's that process. Then we get to clot retraction. So after this clot is formed, eventually it needs to kind of tighten things up. So the whole purpose of this clot is to cover the area, seal the area, and pull everything back together. So the red blood cells and platelets are sticking to that fibrin thread, and the platelets will kind of contract to pull the edges, the damaged edges, closer together, which is why scabs sometimes feel itchy, because they're pulling and stretching. And this can last for up to an hour after the clot forms. Here's the whole pathway. If you didn't like my little diagram there on, hopefully it's not mirror imaged for you and you can read everything I wrote, but if not, it's all right here. Your extrinsic pathway with your tissue factor, your intrinsic pathway with your platelet factors, all coming together to activate factor X, converting prothrombin to thrombin, converting fibrinogen to fibrin, and fibrin is our very dense connective tissue. After a series of weeks or days, eventually this clot is going to dissolve. It's called fibrinolysis. Basically, our plasminogen is activated by plasmon, by thrombin, produced in the common pathway, and that tissue plasminogen factor, or TPA, is released by the damaged tissues, causing this clot to erode. So plasmon is the clot erosion protein. You can pause the video here, go back and review. I'm going to continue and finish out this lecture on this video. So let's talk about some blood disorders. You can obtain blood for diagnosis through a venipuncture. That's the most common, because our veins are superficial, easy to find, they have thinner walls, easier to puncture, and because our venous blood pressure is relatively low, they're going to seal much quicker and release less blood in the process. It's more clinical procedures will examine the venous blood. Typical venipuncture. You can detect something like iron deficiency anemia, which is a nutritional blood disorder, right? This is caused by insufficient iron intake. And this could result in red blood cells that are very small, microcytic, small cells. They're going to transport less oxygen. So this is much more common in women, since our iron reserves are much lower than in men. There's also pernicious anemia, which is a deficiency in vitamin B12. That vitamin B12, or lack of vitamin B12, is going to prevent the normal stem cell division that happens in the red bone marrow. So then you're going to have fewer red blood cells produced. So those red blood cells can be misshapen or very large, macrocytics, the opposite of iron deficiency anemia. And this can result from lack of intrinsic factor as well. So where the protein, intrinsic factor is a protein that functions in our large intestine, and it's used to absorb B12 from our digestive system. So if you don't have intrinsic factor, then you're not going to have enough B12. If you don't have enough B12, you might have pernicious anemia. I don't know why I can't say that. There are other clotting disorders that you could experience, right? Clotting disorders can be brought on from insufficient calcium or insufficient vitamin K. You're going to see the role of calcium is going to continue to play a huge role in all of these body systems this semester. Calcium is required for all of our clotting pathways, and vitamin K is needed for our clotting factors like prothrombin. So if you don't have vitamin K, you're not going to form clots efficiently. There's also congenital blood disorders. Congenital blood disorders are ones that you're born with. Sickle cell anemia is one of them. It's caused by genetic mutation in the amino acid of one of the beta subunits of hemoglobin. This causes our red blood cells to have a more sickle-shaped, and it's going to make our red blood cells more fragile. They can, because of this weird shape, they can catch on the walls of capillaries, block our blood flow, cause pain, etc. So individuals with this disorder have to have 2 copies of the sickling gene in order to have the sickling trait. Those with 1 copy have the trait but not the disorder. Got it? So they're not going to suffer from the maleffects of anemia, but they have the trait. They can pass it on. So they also have increased resistance to malaria. So having one copy of the sickling gene is actually beneficial, especially if you live in a malaria zone, like Africa, India, like that whole bandwidth around the equator. So the infections, malaria is actually an infection of the red blood cell, and the sickle cells are basically destroyed by macrophages, and the malaria pathogen can be destroyed with it. So it's kind of a win-win. There's also hemophilia as a congenital blood disorder. It's inherited. It affects 1 in 10,000 people, more common in males and females because it's on the X chromosome, so it follows a sex-linked pattern of inheritance. It's caused by missing or reduction in production of a clotting factor. It varies in severity. In very severe cases, extensive bleeding can occur with a minor contact, and bleeding can occur at like the joints and around muscles, so it has a degree of impact. There's also thalassemias. Thalassemias are just a general category for inherited disorders caused by the inability to produce proper hemoglobin subunits. So this, again, the severity is going to depend on which protein subunit and how many protein subunits are abnormal. There's also blood infections that can occur. These are caused by pathogens that can enter the bloodstream through a wound or infection. Bacteremia is bacteria floating around in the blood, not multiplying there. Or viremia would be viruses circulating in the blood but not multiplying there, causing an infection. Sepsis is when there's widespread pathogenic infection of a whole body tissue. So septicemia is the sepsis of the blood, where pathogens are now present and multiplying in the blood, spreading throughout the body. Very dangerous condition. So this is a picture of an infant with septicemia from a meningococcal bacteria. So the meningococcal bacteria lives in the central nervous system, but if it gets into the blood, it can go septic and spread throughout the body. We mentioned malaria a little bit already, but malaria is a parasitic disease that's caused by a protozoan called Plasmodium. Plasmodium lives in like mosquitoes, and then when you're bitten by a mosquito, that small exchange of fluid that takes place, the mosquito can deposit the Plasmodium parasite into your body. It kills millions of people every year, and it initially infects the liver, but fragments of it can also infect the red blood cells, and the red blood cells rupture, release more parasite, and so it's cyclical. There's cycles of fever and chills that correspond with this release, and the dead blood cells can actually block vital organs, and it's a very devastating disease. There's also blood cell cancers like leukemia, which unfortunately most of us are a little bit familiar with, right? These are cancers of the blood-forming tissues. Cancerous cells can spread throughout the body. With leukemia, since blood transports everywhere, the first symptoms will usually appear with the presence of abnormal white blood cells, and leukemia obviously can be fatal if it's untreated. There's two main types of leukemias. There's myeloid leukemia and lymphoid leukemia. Myeloid leukemia is characterized by abnormal granulocytes or other cells of our bone marrow, but the lymphoid leukemia is specifically involving the lymphocytes and their stem cells. And there is abnormal white blood cells. You can see this is myeloid leukemia. These cells are enlarged and irregular, and obviously very abundant, much more abundant than they should be. There's also degenerative blood disorders. So something like DIC, or disseminated intravascular coagulation. This is where bacterial toxins can activate the clotting process, converting too much fibrinogen to fibrin, causing small clots to occur in your vessels. Phagocytes and plasmon work to remove the fibrin, and the liver has to work to keep fibrinogen at adequate levels, but it could result in uncontrolled bleeding. If you are overcompensating by not making enough fibrinogen and then you get injured, it could be kind of a never-ending cycle there. So this is actually the last slide of our lecture, and so you can pause this or stop the video here, go back, answer these questions, go through the reading guide, make sure you have everything set so you can take that quiz and do really well on it. Let me know what questions you have. See ya.